Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Coherus Biosciences.
Hello. Welcome to Diagnosis and Treatment, a multidisciplinary approach to effective nasopharyngeal carcinoma care. I'm Dr. Robert Ferris. I'm the director of the Lineberger Comprehensive Cancer Center at the University of North Carolina and chief of oncology clinical services at the UNC Health System. I'm joined by a wonderful panel. I'll ask my panelists to introduce themselves. Dr. Wise Draper.
Thank you for having me. I'm Trisha Wise Draper. I'm a professor of medicine and the Division of Hematology Oncology at the University of Cincinnati Cancer Center. I'm also section head of medical oncology, focusing on head and neck oncology and experimental therapeutics, and the head and neck disease group co-leader.
Beverly Garber.
Hello, I'm Beverly Garber. I'm an adult nurse practitioner and certified otorhinolaryngology nurse. I work at UC Davis Health in Sacramento, California, and I'm on the board of the Head and Neck Cancer Alliance.
Thank you so much. Now let's get right into it. First, I'd like to give a brief introduction to nasopharyngeal carcinoma. We'll talk a bit about epidemiology and clinical presentation. NPC is a relatively rare head and neck cancer in particular parts of the world. It is enriched in Southeast Asia. It arises in the nasopharynx, and it has a strong link to Epstein-Barr virus. The EBV-associated NPC is called the endemic form, and that has the highest prevalence in Southeast Asia and China. Human papillomavirus is a non-endemic form, and some are not virally related at all. The HPV in the non-endemic forms has a lower incidence, and it's more frequent among Caucasians or in Western locations. Histopathologically, there can be keratinizing or non-keratinizing and differentiated type. The non-keratinizing is called undifferentiated nasopharyngeal carcinoma. Dr. Wise Draper, can you tell us about the epidemiology?
Sure. So nasopharyngeal cancers globally occur in about 1 out of 100,000 individuals. There's definitely geographical disparities in prevalence, some of what was already discussed. So in other words, incidence rate in nasopharyngeal cancers in China are about 3 in every 100,000 to 25 to 100,000 in males in South China. EB positive nasopharyngeal cancer rates in the US, though, although it's a lower rate in the US, are highest among Chinese Americans, followed by Filipino, Japanese, Black, Hispanic, and white Americans.
Thank you very much. And tell us a bit about the clinical presentation.
One of the things that's important about nasopharyngeal is really the location of the tumor. Really, for most head and neck cancers, it depends on the location, and that's where you're going to see most of the symptoms. Beverly is probably more appropriate to speak about the presentation because she does see these first, being in the ENT clinic, whereas a medical oncologist, I may see them a bit later. But what I often see are the ones that are a little bit more locally advanced. So they're going to have more symptoms, sometimes even blurry vision if the optic chiasm is affected, but more commonly, stuffy nose, epistaxis, those types of things, as well as just a feel of fullness. Beverly, do you want to add to that?
Absolutely. Thank you. Yeah, working in otolaryngology or ENT, as most commonly known, is often the front line of diagnosing nasopharyngeal carcinoma. And it's also important that a primary care or advanced practice provider in the primary setting is very aware of these early symptoms because they often overlap with other more benign and more common symptomology. So, headache, for example, can be from many, many different diagnoses and is not only specific to MPC, but is an important symptom to make note of. Facial numbness, sometimes the cranial nerves are affected, like Dr. Draper Wise mentioned, is that the cranial nerves are affected. The larger the tumor grows and the more invasive it becomes. So that could lead to changes in your swallowing or your speech or how your face feels. Sometimes there's a lymph node in your neck that is more prominent and growing. The throat can become sore. But I think the most common things that we see that patients will come to us with is that the nose might have episodic bleeding, or one side of the nose might actually be harder to breathe through. But also the hearing can be affected. Oftentimes, one side is more stuffy or plugged or feels full, or patients will say they feel like there's water in their ear, and that can affect their hearing. And it doesn't always come with pain, but ringing in the ear or tinnitus and hearing loss, particularly on one side in an adult that's not associated with other upper respiratory infection or allergy symptoms, is something that we pay a lot of attention to and want to evaluate the nasopharynx.
How do you, what's your diagnostic pathway? How do you initiate a diagnosis for this disease?
A patient presents with symptoms that their primary care maybe has started ruling out more common benign pathology, and there's an indication for an ENT consult. We'll initiate with a full history, asking the patient about risk factors such as where they were raised, where they're born, their family history, maybe some of their environmental or occupational risk factors. We're also very interested in knowing about their tobacco use history and their alcohol use history, as particularly the combination is very risky for these and other head and neck cancers. And then we'll do a full head and neck exam. We'll look at the facial function, the nerves. We'll look at the eyes. We'll ask about vision changes. We'll look in their ears to evaluate if the eardrum and the middle ear behind the eardrum look normal. We'll do a basic assessment of their hearing in the clinic. And then we'll look up the nose. There's a flexible camera that can look up the nose and actually visualize the nasopharynx to look for asymmetry or any ulceration or site of bleeding or a mass that could be concerning for a nasopharyngeal carcinoma. And then the next step would be to attempt tissue biopsy to confirm the suspicion, and that can be done under anesthesia if it needs to be a biopsy of the nasopharynx. In some instances, it might be something that's feasible in the office based on the patient's tolerance and the practicality in that clinical setting. Or if there's a lymph node in the neck, oftentimes they can do a fine needle aspiration to obtain cells from that lymph node that can help direct them to pathology. And then, of course, imaging is very, very important. Typically, we'll get an MRI or a CT scan, and then we'll also, once pathology is confirmed, typically get a PET scan. And that looks at the entire body, and that helps us look for activity and if there's any distant spread of that pathology. And then lastly, they typically, I will say this is often in the medical oncology side, but we also see the ENT providers initiate testing for Epstein-Barr virus or EBV, and in some cases, human papillomavirus or HPV testing.
Tricia, would you weigh in a bit when a patient is referred who's been diagnosed with NPC, often from the ENT head and neck clinic? How do you do a metastatic workup? Do you use these blood tests for a viral DNA?
Yeah, so it's a good question. So often some of the imaging is done, so I'll have the PET scan often available already, as it's usually ordered in ENT before they get to me. But I will order the blood test for EBV. It is important, especially for following after treatment, to know if we're able to clear EBV. Now, in North America, as well as this side of the world, we don't see as many EBV related. And so not all are going to be EBV positive. Sometimes we'll know that from the pathology itself if they've done an immunohistochemistry stain for EBER or the EBV particles. We'll already know if it's going to be EBV associated. But routinely, we will go ahead and order a blood test on every patient. If it's negative, then we know we don't need to follow it up. But if it is positive, then that allows us to continue to follow it on treatment. HPV testing is interesting. It's much more common in our oropharyngeal cancers. But as we know more about nasopharyngeal and some of these are associated with HPV, it begs the question whether we should be doing HPV testing in the blood as well now that we have available testing. But that's all still under a lot of research. But EBV is definitely routine for us to do.
So we're starting to put a multidisciplinary team together here. We have the ENT and the medical oncologist. Who else should be involved when a patient is diagnosed in this way with nasopharyngeal carcinoma?
I'd love to speak to that as an advanced practice nurse. Of course, I believe nursing has a huge role within the multidisciplinary team at multiple stages from diagnosis to treatment and into survivorship. But there are many, many other partners in the care of patients with nasopharyngeal cancer. In some cases, we'll need to include a dietitian to assist in nutrition support, particularly during therapy, as well as our speech and language pathologists. They're very, very helpful in supporting patients when their speech or swallowing changes. And then also from dental care, patients often will need a dental exam or even treatment before starting treatment. And then thereafter, will need follow up care to help ensure that their dental hygiene maintained health. Audiologists are also important because they help with pre-treatment audiograms, as some of the therapies can affect hearing outside of just the hearing effects from the nasopharyngeal carcinoma itself. And so they can help with hearing rehabilitation or assistance with tinnitus. Certainly, if there's vision changes, including an ophthalmologist or optometrist, and then um, endocrinology, if there's any thyroid concerns, we'll speak to later. Tobacco treatment specialists, if the institution has access to tobacco cessation support, that is very, very valuable. And then also, if the patient is of childbearing age, both male and females, should certainly consult with the medical oncologist about counseling for this, as either the therapies themselves will require timely management of reproductive planning. Um, and then, putting the whole team together at various points of time to help manage that patient's journey through the treatment phases is very, very helpful. I was curious, Dr. Weiss Draper, about the mention of hepatitis B and nasopharyngeal carcinoma. Is that something that you test for within your practice?
Yeah, it's a great question. I don't routinely check. Where hepatitis B is important is for some of our antibody drugs, rituximab being historically an important one, but we don't use that in nasopharyngeal. But you can get reactivation, so there's a concern about that. So with some of the immunotherapy, if there's a strong suspicion, you should check for hepatitis B. We do not check routinely, though. And I would just add the one physician group we're missing is radiation oncology, and they're often involved too. But I completely agree with you, Beverly. It's so important that we have this multidisciplinary team, including survivorship early. So I think all of these different members of the team are critical for the successful treatment of these patients.
And just to recap, the patient was diagnosed in the ENT clinic. So we have otolaryngology, we've got radiation and medical oncology. Usually the otolaryngologist is the surgeon, but some of nasopharyngeal carcinomas have a separate group of surgeons who operate in the nasopharynx, the way back area in the nasal cavity that you access usually through the nostril. That can be a skull base surgeon if we think there is a potential to actually get a good resection, either in place of or prior to the radiation and systemic therapy. But clearly, we've discussed having pathology, speech therapy, and our nurse navigators, social workers, and nutritionists. It's the type of disease itself that causes impact on function and quality of life, and the treatments that we select will also impact on that for the patient. How about staging? Tricia, do you want to talk about how we stage based on the AJCC system?
Sure. So, just as in any other solid tumor, we often stage based on the primary tumor size, as well as invasion of important structures, the regional lymph nodes, as well as if there's any distant disease. In general, primary tumor, the T1, T2s are going to be your smaller tumors, not necessarily invading any important structures, whereas your T3 and T4 are starting to involve important structures, making them unresectable. In general, nasopharyngeal tumors are difficult to resect, which is why the treatment is different for nasopharyngeal. One of the reasons why treatment is different for nasopharyngeal compared to some of our other head and neck tumors. But in general, if you have lymph node involvement, that is going to declare you as locally advanced, needing more than just one treatment modality. What's interesting in nasopharyngeal is that even in T2s, if you have like bulky disease, or if there's some other high risk features, such as really high EBV in the blood, those would be reasons to even add chemotherapy. So, doing multi-modality therapy, even in an earlier stage tumor compared to some of our other head and neck tumors. It's also important, as I mentioned, to know the EBV levels pre and post treatment, because that's going to help you determine further treatment and if it's necessary or if you're concerned about persistent disease.
It's complex, but I take your point. The earlier we detect this, the fewer modalities we might need to use. And so, do you use a combination of imaging and the EBV DNA to determine if somebody has a risk of distant disease, or how do you rule that out? And how might that impact on your treatment choices?
Yeah, so if you have a really high level of EBV in the blood, it does suggest that you might have distant disease, but really the gold standard is imaging. I do prefer PET, so that because one of the issues with nasopharyngeal is that it can go to the bones, so you want to be able to pick that up. If you can't do a PET, you can do a bone scan. But it's very important to understand if you have distant disease, and that if it's oligometastatic, especially, those are still curable in a lot of cases. So, although distant metastatic disease is considered incurable in most situations, you can do local therapy to those Mets if it's oligometastatic and still treat them with curative intent. So, it's very important to know that up front, especially you don't want distant disease growing while you're trying to treat the local disease.
And so, the presence of distant disease and tumor burden often impact on prognosis. And as you pointed out, our circulating EBV DNA is very useful. Can you comment on what new treatments, what sort of standards of care currently guide therapy today, and what has been emerging in recent years?
Yeah. So, especially in locally advanced disease, we've had a big shift recently. Now, the trouble with a lot of our regimens is that it is based on the endemic EBV driven nasopharyngeal tumors. And a lot of the nasopharyngeal tumors that we do see in the US and North America are not EBV driven. Nevertheless, the larger studies, we do rely on those. So, we do still treat these patients based on the endemic recommendations. There are some smaller studies that are coming that will hopefully help us differentiate on if we can treat non-endemic different than endemic tumors. especially since the non-endemic tend to be more keratinizing, don't have as much of the poorly differentiated features. The current treatment right now has shifted to doing more induction chemotherapy prior to radiation and locally advanced. Prior, we would do concurrent chemo and radiation followed by adjuvant chemotherapy. In a lot of ways, that was very difficult regimen after patients had finished radiation to be able to get those 3 cycles of adjuvant treatment. And there have been a lot of questions of, do you need to do that every time? Which patients need it? But I was happy to see the shift to be able to give more chemotherapy up front. This allows patients to get that chemotherapy in prior to radiation before they're frankly beat up a bit. With the chemotherapy that's given as induction, it's now gemcitabine based. That's the other big difference is the adjuvant treatment was more 5-FU based, but both still contain a platinum. There are other options that have been used, such as docetaxel, cisplatin, and 5-FU. That regimen is more toxic in general. So I think a lot of us tend to lean towards gemcitabine, cisplatin, but both of them are fair regimens, especially if there's one reason or another that you think a patient's going to better tolerate a certain regimen. And that's in the locally advanced induction, followed by sequential systemic therapy. And these are going to be your more locally advanced tumors. The ones that are a little bit lower stage, you don't necessarily need induction. You can go straight to concurrent chemo radiation.
At the point of diagnosis, is there any biomarker testing? How do you decide and personalize therapy for a particular patient?
Yeah. So with the personalized medicine, it's still a little difficult in the curative intent setting. We don't really have good data if we can use immunotherapy, for example, in the curative intent setting. But there are some studies that are ongoing with immunotherapy, such as in a window of opportunity study to understand, can we use immunotherapy as part of induction? And those are still ongoing. Most of the studies that have been done have been mostly done in the metastatic setting after patients have failed first line curative intent, platinum and radiation, and other chemotherapy. So these studies, there is a plethora of studies that were done with different immunotherapy agents. All of them, for the most part, were positive. So now the first line treatment in the recurrent and metastatic setting is adding a PD-1 inhibitor. And as I mentioned, it can be multiple different PD-1 inhibitors at this point. In the US, there's been more pembrolizumab and nivolumab, but in Asia, it's been more the toripalimab and some of the others that have been used. But all of them have showed a survival benefit. So it really changed the paradigm for these patients. And these do not require a positive PD-L1. Now, with the PD-1 and therapies in the subsequent settings, PD-L1 positive was used to suggest if you can use it after failure of chemotherapy in the first line recurrent and metastatic setting. But for the most part, in these upfront treatments, the combination with chemotherapy is pretty well accepted.
And as you said, to reiterate, in other forms of head and neck cancer where we're giving a PD-1 immunotherapy as a monotherapy, sometimes the PD-L1 testing is used, but you're saying in nasopharyngeal carcinoma, it's combined with chemotherapy much more routinely.
Correct. And I think some of that speaks to just the chemosensitivity of a lot of these tumors. But yes, we use it in combination in these patients.
That's great. And when we use these therapies, how does that impact on coordination with different treatment teams? Are there others in the multidisciplinary team who we may want to call on, particularly in this era where we're using immunotherapy?
Yeah, so that's a great question. So first, just in the locally advanced setting, we're gonna I'm rarely gonna be giving treatment without our radiation oncology colleagues. They're gonna be coming in for the concurrent chemo radiation. So they're involved early on, though. I want to make sure the testing, the imaging, that I'm collaborating with them to make sure that I'm getting the imaging that they need in order to determine the radiation fields once we're ready to begin concurrent chemoradiation while I'm giving induction. But in the recurrent and metastatic setting, sometimes radiation oncology and our ENT surgeons are very important, especially for palliative reasons. If we need support, and sometimes for those oligometastatic disease, we may be using radiation. There's still a lot of questions about, does radiation enhance immunotherapy? And so there are still trials ongoing and trying to understand, does that combination provide benefit as well? But with immunotherapy itself, this brought on a whole new era of side effects and needing to involve other specialties. This was one of the many times that we've realized we need help from pretty much everyone, because immunotherapy can cause a side effect in any part of your body. There are some that are more common, a simple skin rash, but if it gets worse, we often have to involve our dermatology colleagues. Colitis, you give steroids to treat colitis. So in that situation, ideally you have an actual diagnosis and you get a colonoscopy. So we're involving our GI colleagues. Same with hepatitis, what we may also be involving them. But you can pretty much come up with any specialty needing to be involved in the medical field, and some of our subspecialty surgeons, because of all these complicated side effects, especially the endocrine side effects, which often require hormone replacement, but also may require steroids. And I'm sure we all remember endocrine pathways are not always straightforward, and understanding what is the actual diagnosis. And so we're calling for help quite a bit now.
And you mentioned this a bit, how you treat immune-related adverse events. Could you comment a little bit more? Does it depend on the length of time or the severity?
Yeah. So with immunotherapy side effects, a grade one often doesn't need any treatment besides maybe if it's a grade one rash, some topical treatment. In general, most autoimmune related side effects are going to require steroids for control. Grade three for sure. Some grade two require also steroid treatment. If they become refractory to steroids, then the next step is some kind of immunomodulator, and that depends on the type of side effect. But those are often involving our other specialty providers to help us determine what do we need to control those side effects. And then finally, as I mentioned with endocrine side effects, those often require hormone replacement, and those side effects are often permanent. So that is something that is very important that we warn patients up front that they could wind up on long time endocrine therapies.
Thank you. It's clearly complicated, although the advent of adding immunotherapy to the systemic therapy and radiation is really exciting. Obviously, we've talked a lot about toxicities, multidisciplinary care, and I wonder, Beverly, could you comment on some of the patient-oriented resources and how we ensure or at least optimize long-term quality of life?
Absolutely. Yeah. Seeing patients prior to treatment and then after treatment in their surveillance in their survivorship period, you see a lot of the impacts that the treatment has, while it's to save lives, prolong lives. It's amazing to see the science progress, but it doesn't come without a lot of side effects that are lifelong in many cases. So, the more common initial toxicities that I see after treatment typically relate to a patient's hearing, or even something as simple as the skin in their ear becoming more dry and build up and needing routine cleaning, or more at risk of external ear infections that need maintenance. They have sometimes neuropathy because of the chemotherapy agents, and that can affect their balance and their sensation. Dry mouth or xerostomia is a very, very big impact that can affect your teeth and your oral hygiene, your taste, and your swallowing function, which is another reason why our dental care providers and our speech and language pathologists are integral in helping manage patients long term. But I also want to mention and highlight distress screening. and the role of supportive oncology or psychologists, because a lot of these treatment effects also play a huge mental toll on the patient as well as their family or caregivers. So that's the benefit sometimes of a palliative care consult, to help manage these long-term side effects as well as address any of the distress, or even depressive symptoms that patients or their family members need. And then I reinforce the need for long term follow up. We see patients on a routine basis for exams, check ins, making sure that their quality of life is maximized to the best that we can.
Wow, thank you both, Beverly and Tricia. Amazing, great information for a very challenging disease. I'll try to summarize the key takeaways. Because this is often a viral origin, we have biomarker testing such as EBV DNA and sometimes HPV, depending on the part of the world where nasopharyngeal carcinoma is identified. When we get to immunotherapy, we don't typically use PD-L1 testing as we do in other cancers, and that's because we're giving PD-1 plus chemotherapy. Multidisciplinary care at diagnosis and throughout treatment is the key to ensuring that the right patient gets the right treatment at the right time, and that we understand the impact of our treatments. We individualize based on tumor burden, whether there's metastatic disease or not, and try to use the right intensity of therapy depending on what that patient needs. And we can use the circulating EBV DNA as a biomarker to help us to understand whether the treatment is having an effect. In the advent of PD-1 inhibitors such as toripalimab, pembrolizumab, and others, the immune-related adverse events have become issues that we need to be aware of. They're manageable. There are very clear guidelines to manage immune-related adverse events, and often, in some cases, we can continue the immunotherapy or restart it if we're able to get these back down to baseline levels. The key is that it's a very challenging tumor in a difficult part of the body. And so supportive care and quality of life are important decision-making features that help us over time to try to get the patient back to as normal a lifestyle and quality of life as we can, recognizing that it's a very challenging and difficult road for them, and the multidisciplinary approach has the best outcomes. So I'd like to thank our panelists. Tricia, Beverly, wonderful, and thanks so much. I learned a lot. Thank you to the audience for participating, and please continue on to answer the questions that follow.